Why are we under siege as a field? Tell me what that means to you, and more importantly, how do we get out of siege, if whatever that that metaphor is?
Yeah, well, public health is going through a transformational phase where we're moving from being silent and invisible to being extraordinarily visible. And I think the under siege means that people now see us. Many things that we used to do that were invisible to people is now very visible. And in many ways, COVID was just our turn in the fishbowl because the anti-establishment movement's gone after police, they've gone after teachers, they've gone after librarians. So in many ways, that was just our time in the fishbowl. We have to transform our own thinking from the wonders of being invisible to the importance of being visible and being engaged with communities. The groups that have successfully defined their value in the eyes of the public, the people they see every day helping them out, are the people that they have value for. So public health gives you a better
police,
job.
yeah, those kinds of.
Absolutely.
We spend a tremendous amount of time collecting the dots. We need to spend just as much time in connecting those dots. And that's what Public Health Connects is all about. My name is Dr. Umair Shah. I'm the Secretary of Health for the great state of Washington. This is Public Health Connect. It is a super honor, Georges, to have you here. Thanks for joining us.
Well, thank you very much for having me. Absolutely.
Just tell us a little bit about yourself and what your career has been, and then let's segue into APHA and what's been happening at APHA.
Well, I went to medical school on an Army scholarship, and
thank you for your service.
Well, thank you, and did my residency in internal medicine, and then got dragged into emergency medicine. I literally was an intern the day the Army opened its first emergency medicine residency, and my faculty advisor was a guy who put the emergency medicine residencies together in the Army. And of course, when I finished my residency, I got an offer to actually become faculty of one of the Army's emergency medicine residency programs. So I really spent the first half of my clinical career practicing emergency medicine.
Okay. And then you decided public health, emergency medicine and clinical work was not enough. There was something else. So what was that something else?
I was minding my own business. I was chief of community medicine at the city hospital, which had the ER and the trauma center and all that kind of stuff. And then my phone rings and the mayor says, "Have I got a job for you?" And I ended up being the DC Health Commissioner for almost 2 years. Then went in and out of public health for a few years, worked as an emergency physician, and then came back to the city as one of the assistant/deputy fire chiefs. And actually ran the EMS system in Washington, D.C.
Fire chiefs, that's okay. I did not know that.
I was
okay.
I always tell people, I worked for the fire department and had a little fire car, which good
putting
news.
out fires, hopefully not. But yeah.
Well, it was a good news. I could park my car in lots of nice places, which was a good thing.
Got it.
But then I eventually ended up coming to Maryland as a deputy health officer for public health services, which is a fairly large department, $1 billion budget, big state level.
Sure. Yeah.
And part of a mega agency. And Maryland has a mega public health agency, which includes Medicaid and just about everything you can think of in public health. So after 4 years as deputy, I found myself suddenly secretary of health in 4 years. And as you know, that was a challenging time. We had 9/11, the anthrax letters, big 750-person foodborne outbreak, identified a new disease called Pfiesteria, which is kind of a red tide.
Yeah.
We had a drought. We had a hurricane that went through southern Maryland. So, you name it on the public health, 10 essential services and 10 functional services, we did them all.
Wow. So, this speaks to me. So obviously as you know, emergency department, ER work for so many years, and also doing public health, and then doing emergency disasters. And so what I'm hearing here is that you were
taking care of individual patients, and then you were doing population health, essentially disaster medicine, and maybe it wasn't called that, and bringing those two together. How did you intersect the two, the experiences of one with what does that mean for a population?
Yeah, well, emergency medicine practitioners, for all practical purposes, are the population-based practice within clinical care. I mean, all comers.
Right.
We're very functional. We're the front line of the surveillance system for many diseases that first enter the community. In the military, you see yourself as a population health doctor. I mean, we see the military as not such much a closed system, but the physicians and the health system is there. It's for the community.
Yeah.
It's the community of the military, which includes both those on active duty and their families. So it's kind of drilled into you that you are kind of a population-based person. You do a lot of administration and management very early in your career, as I did.
Sure.
And actually, when I was for my 2 years in Tacoma, Washington, I actually ran the outpatient side of the emergency department, which was the acute walk-in ambulatory care component. And I actually moonlighted in a small urgent care center on the back of the Nisqually Indian Reservation in Yelm, Washington.
Is that right?
Which of course meant we referred anyone who was really sick down to St. Pete's in Olympia.
Oh, wow.
Yeah.
Okay.
So I know the state.
So tell me a little bit about, really quickly before I get back to APHA and tell us about what's going on at APHA. How was your Washington experience? What was it like to be in Washington? And is it an incredible state, beautiful state? So tell me about those experiences. Like, sum it up for me.
No, I loved it. I mean, my wife and I enjoyed it. I think I wore a coat one day for to go in the office or something. Never had to wear a coat. And of course, as you know, when the sun comes out, Mount Rainier is there.
It's heaven.
That's heaven.
Yeah,
You just sit there and say, So we drove up to Snoqualmie Falls and had their buffet. I don't know if they still have it, but the wonderful buffet up there. But no, we had a wonderful time for those 2 years. And in fact, if I hadn't gotten the offer to come to Walter Reed to be chief of emergency medicine for the military, I might have still been there.
Wow.
Yeah.
Well, we would have been connected. Yeah, I don't live far from there. So my family, your family would have been right down the street from each other.
There we go.
All right, let's talk about APHA. A lot going on. American Public Health Association, America, Public Health, and Association, bringing it all together. What's happening at APHA, and how do you bring all the different voices and different perspectives, different issues all together?
Yeah, APHA has been around since 1872, right? So we've been around a long time. And I think what's important is that there isn't a debate that has happened in health, and in fact, many non-health issues in the social determinants area, in which APHA hasn't had played some part in. All right, whether it was the first vital records requirement in this country, whether it was infant screening for genetic disorders, whether it was the first debate around Medicare and Medicaid when the AMA was saying, no, we don't want it. APHA was saying, absolutely, we do. So we've been involved. Clean Water Act, Clean Air Act. And I think the secret in APHA, since we're kind of about everything you can get at the table, is to try to find ways to focus. So we focused on helping the field build the capacity to do their work. And we focus on of public health. Well, we work on trying to build the capacity of the field.
To build the capacity of the field to do its work.
To do its work.
Okay.
And, access to care, health equity, and building public health infrastructure are the three foci that we do on everything that we do, and try to get people to think about what happens under that umbrella, despite the many, many things that you could do on your plate. And then obviously, the crisis of the moment.
Sure, and there was always a crisis. Yeah, absolutely.
Yeah.
So speaking of crisis, I'm looking behind you. There's a book that we have propped up, Public Health Under Siege. And, I see our colleague, Brian Castrucci, as the top line co-author. And right underneath him, it says, Georges Benjamin. Dr. Georges Benjamin. Why are we under siege as a field? Tell me what that means to you, and more importantly, how do we get out of siege, if whatever that that metaphor is?
Yeah, well, public health is going through a transformational phase where we're moving from being silent and invisible to being extraordinarily visible. And I think the under siege means that people now see us. Many things that we used to do that were invisible to people is now very visible. And in many ways, COVID was just our turn in the fishbowl, because the anti-establishment movement's gone after police, they've gone after teachers, they've gone after librarians. So in many ways, that was just our time in the fishbowl because of the enormous challenge of COVID. But I think the way to think about this is that we have to transform our own thinking from the wonders of being invisible to the importance of being visible and being engaged with communities, to define our own value is very, very important. You know, the groups that have successfully defined their value in the eyes of the public, the people they see every day helping them out, are the people that they have value for. So public health needs to do a better job.
Yeah, those kinds of.
Absolutely.
Yeah.
I mean, when I was in the fire department, you know, I actually had a fire department uniform, and I was a whole lot more visible than my colleague who was the Commissioner of Health in DC at the time. And
yet both serving the community different ways, but absolutely every single day, night, weekend, holiday, serving the community.
Absolutely.
Yeah.
Absolutely.
So it's interesting you say that. You know, I've really over the years, as you know, had this real contention that we have to be more visible. In fact, I testified in Congress to say we have a hashtag invisibility crisis, right? This is pre-pandemic. It was really about the fact that we are so invisible that when we do our jobs, either nothing happens or we prevented something from happening. And then at the same time, COVID and the pandemic, and then other issues, whether it's been community violence or whether it's been challenges around maternal child health, has now all of a sudden brought us to the forefront of visibility. And yet we don't always have the skill sets to go from invisibility to visibility. That takes some training, development, etc. Talk about what does an APHA or the field of public health need to do to help support the capacity of transition or transformation from invisibility to now you're in the forefront of a living room for everyday Americans?
I think the first thing we have to do is convince our colleagues to take the first leadership step and announce that they are the chief health strategists in their community. Because if they're not going to be in charge, due to the fact that they're the only entity in our nation that has the legal responsibility for the health in their community, we need to own up to that, and we need to make sure people know, we're here. That doesn't mean that someone else can't lead on a different day. That doesn't mean that we don't partner with others, but someone has to be in charge, and if you have the responsibility, do it. So I always said, if you're in command, be in command. Be in charge. If you're in charge, be in charge. So I think that's the first thing we need to do. Second thing we need to do is continue to tell our story and celebrate our successes. We're going to have setbacks, we're going to have failures, but the way to address that, I think, again, is to talk about it. So, for example, imagine a process where the HHS secretary comes out each year and says, these are the health goals for the nation. We actually have healthy people goals. And it's not something the secretary has to make up. And then every year, give a state of health to the nation report and take credit for that. The other thing I think we have to do is get rid of this false dichotomy between medicine and public health. So remember that the rest of the world looks at things as public health, and medical care is underneath that as a component. Here we have divided it artificially between the two. And then, of course, we do the medical care stuff when no one else will do it, and then pretend like we don't.
Yeah, that's fair. So it's interesting you bring this up because it really gets to, even in our agency, we've had, as you know, I've talked to you about this for a long time about our transformation as an agency, and we have really had the underpinnings of cornerstone values of equity, innovation, and engagement. I was going to ask you the question, do those resonate with you? But I think that's the wrong question. Let me ask you this. How do you see the intersection of equity, innovation, and engagement? How do those values speak to not necessarily APHA as a agency organization, but the field of health, the field of public health, equity, innovation, engagement? How do those cornerstone values really define what we need to be doing as a field?
Yeah. You know, our goal is for people to have optimal health.
Yeah.
And optimal health, by its very definition, means you have to have equity across the systems, but in an optimal way, because everyone's not going to be equal. We're biologically different, our exposures to the social environments are different, but to the extent that we can drive and strive for being as healthy as you possibly can be is important. But that only occurs with engagement and thinking out of the box, which is your innovation point. So those three things come out about achieving optimal health as a goal, and achieving equity as part of that. Doing that by engaging the full spectrum of people across the sector in a collaborative way. And then using all the innovation we have. You know, we have so many disruptors out there. Social media, vaping, e-cigarettes. We have politics that is dramatically now playing our role in a much more assertive way. We've got to find innovative ways to address those things, become better schooled at doing it. So we have to stop being afraid of the word politics, because if you're going to do policy, which is what our book said, the best way to take care of people, you can take care of them one by one, but if you really want to make progress, you've got to do it on a population basis. If you're going to do it on a population basis, that almost always means you need to do policy. And if you're going to do policy, then you got to be involved in politics, but you don't have to be partisan.
Okay.
Okay?
And can you unpack the two? Because I know what you mean.
Yes.
But unpack that. Public health is inherently political, and this word partisan. And I'm going to add in one other word in here, leadership. Because it takes leadership to really unpack, demarcate, although there's relationship and there's integration, political from partisanship.
I think the issue is politics is, if you go back and pull the definition out, it's the art of convincing people to your position.
Sure.
And thinking about how that works. And by the way, we want to be science-based. There's something called political science. We've got to be better at doing that. The partisanship is when you do something for a purpose that is driven to one side or the other. And I've always argued the way to avoid partisanship, where you're taking sides in a manner that, quite frankly, is either for financial purposes, for one benefit of one group or another, or some benefit that may or may not be appropriate. I've always said the best way to stay out of that part is always do what's in the best interest for the patient as a physician, or the community as a public health broader practitioner. If you're doing the right thing for people, then the partisanship falls away. Because you can always argue, this is my core belief and this is why I'm doing it. This is why we think it will work. And then what your goal is to get the people that have political views that might be different to buy into that. And so the political science part is convincing these two groups that you're right. And at the end of the day, you want to address the indifferent middle, because in many ways they're often indifferent.
Right.
If you can get the middle convinced, then the extremes, and you can narrow them,
sort of fall
you can
in
bring
place.
them in a little closer. Now, you may never make them happy,
right?
Because that's why they're on the extremes. But if they see that you're fair, then they often will support you. Not always, but they often will support you.
I love that, and it's such an incredible lesson for today, what we're seeing in our country. And so I'm going to, as we're closing up here, because I wish that I could turn the clock and go back to the beginning of this conversation so I could have another hour to talk to you, but I know we can't. I'm going to ask you with a crystal ball, not 20 years from now, but I'm going to say in 2025, 1 year from now, or maybe at the next APHA when we gather together. What gives you hope that as we get past whatever this is in the next few months and that beginning of 25, when we turn the calendar to next year, what gives you hope that we're going to get there, that it's going to be a positive, something that is optimistic for us?
Well, you know, I've been here in, as I say, sunny Minneapolis at our annual meeting for the last 4 days.
It actually has been sunny. That was not a joke. It was, I guess, 70, 75 degrees. Yeah,
Yeah,
it's surprising. And it's snowing this weekend, so I don't know what that's all about. Yeah.
Absolutely. Well, you know, it's the people. You walk by and you've got people here who are absolutely dedicated to the work that they do. They get up every morning. First thing on their mind is, how can I improve the public's health? The last thing they think about when they go to bed. And that's true. And when you talk to these folks, they're smiling, they're engaged, they're active, they're in these sessions, they're here to learn. And I think that's what gives me hope. And when I talk to the younger folks, the students that are here,
Yeah, absolutely.
they're absolutely phenomenal. And so that place is rejuvenating. This meeting is rejuvenating for the people that come here.
Yeah.
And that gives me hope.
I love that. I love that. Okay, let me grab this apple. This is our Be Well Wa apple, and this is our initiative that we launched recently, and it's really directed at 8 million Washingtonians, Washington residents, people of Washington, and you were one of them for 2 years. I just want to make sure you remind you. And it's around health and wellness, movement, nourishment, emotional well-being, social connection. And so one of our questions to our people is, find your apple. What's your apple? Some people are saying it's jazz. Other people are like, it's meditation. Other people are like reading a book or walking my dog or spending time with family. So Dr. Georges Benjamin, esteemed friend and public health leader, I will give you this apple. As I give you this apple, I'm going to ask you, what is your apple? What gives you that joy that makes you want to come back the next day?
Yeah.
So let me hand it to you. Tell me, find your
Well,
apple. What's your apple?
It's my grandkids. It's my grandkids, knowing that I'm working to create a future for them. That's what helps me get up every morning.
I love that. I love it. Georges, thank you so much for the time. Thank you for what you do. Thank you to your team. Really appreciate it. Absolutely.